scan. Andre Simon is a consultant cardiac surgeon and director of heart and lung transplantation and ventricular assist devices at Harefield Hospital. Once qualified in cardiac and thoracic surgery, he continued his training, completing his doctorate at Christian Albrechts University and a higher doctorate of medicine at Hanover Medical School. We are so excited to hear you speak about ventricular assist devices in the ACHD population.
Thank you very much. Can you hear me?
Mm-hmm.
Okay, thank you very much. I apologize for not being ready when I was supposed to. I had a little problem here. So I'm going to rush through this. I have way too many slides, but in true surgical manner, they have very little depth, so that should be possible. Now, from a ACHD, from a VAD perspective, is interesting because it presents with a wide range of hemodynamic abnormalities, biventricular pressure and overload lesions, univentricular failure, all sorts of stuff, which goes way beyond the standard and the initial way of implanting VADs. And there are multiple clinical presentations because some patients are diagnosed and palliated in childhood, some in adulthood, and then they have sequelae of untreated hemodynamic abnormalities. So these patients, from a VAD perspective, are a lot more complex than the usual VAD patient. And then, of course, there are the lesion-specific complications and the natural morbidities of aging that complicate this even further. Now, when you look at what is done, and there's not a lot of new data out there in the real world, when you look at the Intermax registry, you can see that there is, of course, not a lot of VAD implantation going on, and the cohort actually changes over time, but the survival outcome is similar even in the setting of complex congenital disease. This, of course, can be explained by very careful patient selection and all of that, so you're not treating those absolute catastrophes. Nonetheless, it's doable and it's possible. And when you look at this here, months after device implants, the Intermax data here, you see that there is not that big of a difference. Obviously, in numbers, yes, because there's only 89 VAD patients in the ACHD population. Nonetheless, there is not that much difference with the prospective implant survival. Now, and again, when you look at the data from the UNOS network, then, for instance, there is no difference in 30-day mortality in the implantation. Although, of course, for a VAD patient, that's not a really interesting number, but it is the perioperative mortality. Now, milestones, I'm going to brush through this very quickly with you. In VAD development, I think, are interesting because a lot has happened. So the first VAD ever implanted was this one here in 1828 in a fairy tale by Wilhelm Hauff. And this guy is a coal maker, and he actually gets his heart exchanged for a stone for various reasons, because he wants to be rich and famous and wants to marry a girl. So his heart is then actually taken by this by a spirit in the forest who stores it in a glass jar, and he has this stone, and then lives with that and discovers that many other people have gone there before, but the stone has serious side effects, as does VAD therapy still have today, and he is actually not quite happy in the end with this. I'll come back to this later. So the first, then for a long time, nothing happens. And in 1969, the Liotta heart, which is actually a total replacement heart, a total artificial heart, was used as a first VAD by Denton Cooley, and with a successful transplant at that time, 69, successful transplant, medium-term result performed afterwards. Then in 1988, the Biomed, and I love this, BVS 5000, I don't know why it's 5000, it was an air-driven extracorporeal pump. You can see that here. There are two ventricles, there are atria and ventricles here, and it is driven by air and, of course, gravity. At that time, these devices had two chambers because pumping wasn't really possible with one. As you can see, quality of life is slightly suboptimal with this, and it's actually only used for a short term with enormous complication rates. Nonetheless, it was there. The real game changer was this by Thorotech, which started out to be as an external VAD, the PVAD here, which had two pumping chambers, so you could use it for uni or biventricular support with mechanical valves that they were hanging out here. People used to go home with these. They used to do a lot of those in France, and people had their ventricles hanging out and had this little like shopping cart trolley behind them and pulled them. And we used to call this lovingly thrombotech, which indicates one of the main complications that you would experience with such a device. Nonetheless, they could work for quite a while. And then this changed to an internal device. So this is basically the same shebang, but now it was internalized in this metal part, and which was supposed to give the patient a better quality of life, and it did actually. Then the iBiocore was there. That was a fully implantable system, driven here with these batteries. One of the main problems of this system is that it is a displacement device. It actually pumps. It has an expanding and contracting chamber, and it needs some sort of expansion chamber. And this here is the expansion chamber, which used to go into the axilla region of the patient, and that would break after a maximum of about half a year. Other than that, it didn't function. Then the total artificial heart, which is still used today, mainly in the same version, just tiny changes here in 1982, which is the only currently commercially available replacement device, a total artificial heart biventricular device. Another game changer was the HeartMate 1, and that was when they started to do the trials comparing medical therapy really with device implantation in 1991. A displacement device, again, you see the size of this, it was quite heavy, and it was a rotating, it was an engine, basically, electrical motor rotating. Each time it rotated, it went up on a helix and compressed the chamber and then fell down again. You could hand pump this. All these devices were still hand pumpable, and it did have a lifetime of about 1 to 2 years because the mechanical wear and tear would break that device. But until that point, it had excellent survival rates. Patient had a good quality of life, and this was truly the advent, I think, that was truly the advent of modern ventricular assist device therapy, followed by the HeartMate 2, different device. Now this is a open device, no more valves, and it only creates a pressure differential. It's an axial flow pump. This was when the numbers really started to go up. This is how it was implanted. Still, numbers started to go up with patients, and patients had a good quality of life. And we actually have still one patient on a device like that who is almost 16 years after implantation. Jarvik 2000 was another device that came out. Now, this is a very small device, which made it more versatile, but the most interesting part of this is that it had the electrical connection at a pedestal derived from our friends in ENT surgery, and this actually made it quite comfortable for the patient. The patients do not really have any problems with infection of the driveline, which still remains to be a problem. The device has never made it like the others, but it is still around. It's still being used, and it's actually been recently used as the first fully implantable device with an internal battery and controller and transdermal charging system. Heart Assist 5 has come and gone. The interesting part about this device was that it, for the first time, had an exclusive flow probe, actually enabling you to see how much would actually be pumped, because all the other devices utilize an algorithm and calculate the flow, which can either be true or not, depending on your clinical situation that you're in. Then the HVAD came, which was another game changer, a very small, versatile device. This is now not a this is a centrifugal pump, and it is still widely in use. It's a last generation device. And then the Synergy device came, which was a very small device, about the size of your pinky, implanted in a minimally invasive fashion, and it is currently not available any longer. However, the main point of this device was that it would provide only partial flow, which at the time was thought to be a non-starter concept, but it actually turned out to be that partial flow support is an excellent concept for the majority of patients, and the future will probably lie within devices that will be able to supply partial flow. The latest development was the HeartMate 3. This is a fully magnetically levitated device, very similar to the HVAD. It's a centrifugal pump. It's implanted in the same way, and there are many similarities. And of course, the companies also would like to point out differences between the devices, but there are many similarities. And the last one was the AVAD, which was, again, basically the Heart Assist 5 in a refashioned way. The interesting point about this device was that it had a telephone controller integrated into the controller here, so you could read access your patient's data anywhere where they had the telephone access, which was quite sexy, because the patient could call you up and say, I got a problem, this alarm goes off, and you could then log into the device and see what's happening. Future developments include mainly the resurface of the Circulite C-pump surgical system because of the advantages of partial support, and a fully implantable system. Now, there's one system out there that has been implanted successfully, and both major companies, both major players, Abbott and Medtronic, are working on fully implantable devices. I have seen one of them, and they are very sexy now with the COVID delay in everything. We don't really know when they're going to be coming out, but the plan was that maybe by the end of next year we would see the clinical emergence of such a device. This would, of course, take care of the skin-breaking driveline problem, so no more infections, which would then make anticoagulation easier because you don't have the infectious problems, and also quality of life for the patient because the battery is inside and everything. Transdermal charging would be available, and this will be a true alternative to heart transplantation. Now, at Harefield Hospital, we use these devices, and also, of course, in congenital patients. But the interesting thing, and I just want to highlight this here, is that you can have different concepts with your device. Heart transplantation, by definition, is always destination therapy. But you can, of course, bridge a patient to recovery, to decision, or to transplantation, or have them on such a device forever, as in a heart transplant alternative. And I think when you look at the congenital patient population, all these different therapeutic concepts may play a role in the future. Now, at Harefield, we implant VADs, and I'm going to go into the surgery a bit now. We have developed our technique, as have others, and we have specifically developed our standard operating procedure. And this is very important, specifically when you go into the ACHD population. You need to have a full assessment of your patient. And this includes a full surgical assessment, renal function, your CT thorax. Very often you had previous surgery, a right heart cath, no estimation, an echocardiography, and you got to have a good surgical plan, meaning you're going to know what you want to be getting into. Some actually use 3D reconstruction by a CT scan in order to come up with a surgical plan, specifically when it goes to, further, and when we're talking about implantation of a total artificial heart. But this has also been done for HVAD implantations and others. You have to prepare your patient. These patients don't just walk into the hospital and get this. They are very often on IV milrinone, or they should be, or maybe sildenafil to optimize pulmonary artery pressures and perfusion, renal function. They maybe should undergo prehabilitation. Many of these are not in such a good state when they come to the operation. And as you all know, your overall physical situation has a severe impact on 30-day mortality. Fluid management is very important because it translates into the post-surgical period when your patient's on the intensive care unit, RV failure, renal function, all these things. And you should freely consider other options if you're not happy with your patient, and optimizing maybe with the use of extracorporeal circulation, because that can significantly lower your post-surgical mortality. Anesthesia is an important point. You all know that. And we not only do they have to assess the patient, they have to manage them. Everybody should have a TOE in the operating theater. That is a very, very valuable tool that should be used in these patients. Everybody should have a Swan-Ganz catheter if possible, if the anatomy allows you to do that, because pressure measurement and flow measurement in your pulmonary circulation is essential for complex patients in order to manage them appropriately afterwards. The people in our institution have a double lumen tube because we have a specific way of implanting. We don't do sternotomies. And everybody should have nitric oxide ventilation, at least available, and not at the, oh, I need it at the end of the operation. And then, of course, we do minimally invasive for lateral thoracotomy implantations. We have even looked at our positioning, and this is for how we position our patients in a specific manner that here you can see that allows you access to the side of the patient, to the lateral part, the anterolateral part of the thorax from both sides. And that, again, makes it a lot easier to do your operation. Surgery has to be adapted to the patient, and you can either do a classic sternotomy, and this is how it looks when you implant by a classic sternotomy. We do all our VADs on bypass because not going on cardiopulmonary bypass is only good for your CV, and we're all too old for that. We don't need that, so we play it safe for the patient. There is no upside in doing it off pump if you don't have to. It's a lot safer, specifically protects the right heart and does all sorts of other things. So we do everything on cardiopulmonary bypass, but this is how sternotomy looks, ventricular assist device implantation via sternotomy. This is how it looks when you think that you want to do transplant your patient later on, and you can see that the outflow graft here is coming behind the right atrium and superior caval vein into the aorta. That allows placement of the outflow graft far away from your reduced sternotomy access site during transplant. It's a bit more complex to place, but at the time of transplant, it's very nice to have that. And of course, if you want to do some ECLS prior to your VAD implantation, you can, for instance, put the outflow graft already on the aorta. If you want to have a central implantation, you can then cannulate your wherever you want to, right side with oxygenator or left side without oxygenator, and then have your patient actually on extracorporeal life support, rehabbing, quote unquote, on the unit. And we have patients who go on ECMO or go on systems like that, and they leave the intensive care unit, you go to the transplant unit, and they go onto a bicycle there, on a treadmill, and they train, and they are better for the operation later on. And then you can do what we call euphemistically minimally invasive surgery. Everybody usually uses a left anterolateral thoracotomy, which brings you very nicely to the point of where you want to implant the VAD. And then there are multiple choices that you can have in order to implant your outflow graft on the right-hand side, depending on your personal preference, the operation that you want to perform, and all this. And we, for instance, use in a standard the left and the right anterolateral thoracotomy, which is the same approach that we use for minimally invasive lung transplantation. It's a routine approach for us. That's why we use it. And this is how that would look. For instance, you see here the left anterolateral thoracotomy with the heart and the apex of the heart here. And that's exactly where you want to implant. You're automatically there where you want to implant the VAD. And this is on the right side. You can see the aorta nicely through here, and the right atrium. This is good access. Sometimes it's a bit deep, and you have to, of course, train yourself how to do this. But this is all doable in a standard way. We implant, again, being on bypass. All these patients usually go on bypass via the groin. And we utilize, for instance, an LV vent, which is a Foley catheter, in order to luxate the ventricle out of the chest a bit. It makes your access easier. And all this is standardized, no problem. Other people use others, and they have standardized their approaches too. If you want to do something with your aortic valve at the same time, you can use this approach here, where you have the standard approach for minimally aortic valve replacement, and you can then access your ascending aorta, replace the valve through that if the patient has aortic regurgitation, and then you can anastomose your outflow graft there. So that's standard too, no need to do a sternotomy. So the considerations is obviously, what do you want to achieve? Do you want to have bridge to recovery or destination therapy? You know, how bad or good is your RV? Do you want to do a transplant later on? So all these will influence your surgical approach. Or other things. Do you want to do a door procedure, ventricular reconstructions? All these can be done via lateral approaches if you plan appropriately. And then, of course, how's your patient going into this? If you have a previous sternotomy, maybe you don't want to go through there. You got your patient after bypass operation with an IMA graft. All these things, if you have an arteriopath or a patient who just doesn't have access to vessels any longer because of multiple operations during his adolescency or childhood, or acute MI, we want to wait on extracorporeal life support for structures to form scar tissue in order for you to be able to do your operation. If you, for instance, have somebody who just does not provide access to the right side of the chest, you can do it through a single-sided left thoracotomy. You need to clamp a bit differently. This is basically via the neck into the aortic arch, but you can access the aortic arch through there and implant your outflow graft on the left side into the aortic arch, which is, from a flow perspective, better than going into the descending aorta. So all this is doable, and you see that Gore-Tex membrane on the VAD, covering the VAD. That is in order to prevent adhesions at a later time when you want to go back in and do whatever you want to do. If you have a patient who doesn't provide access to the periphery, you can utilize a multi-armed outflow graft, as you can see there, and you can anastomose your outflow first to the aorta, and then you can go on bypass via this arterial arm here. You clamp in between. You only have to, and then you can vent after implantation, vent your device into this arm here, into your cardiopulmonary bypass. In the end, you just have to cut that one and that one here, and then you can take out the device. Sorry, you can take out disconnect, and you can let your device run. And that's how this looks inside of the patient. You can see that the outflow graft here actually is coming. The VAD is already on the other side. The outflow graft is coming from here underneath the superior cable vein into the aorta, and we run our cardiopulmonary bypass via this second arm. Again, you can also go on extracorporeal life support via lateral approach, which and you can put your graft on it prior to that, and then you have only one side open. You have your device in the running there, and you can easily rehab your patient on extracorporeal life support and convert at a later time. Other stuff would include, again, I did see this before, the optimization of ankle insertion, for instance, if you have a bypass patient, or if you have Fontan patients, for instance, different ways of implanting the VAD in order to support that Fontan circulation. And that will be coming up, because a VAD can just as well act as a single ventricle of the patient. You may have to consider certain flow and pressure limitations and do other stuff, but you can use that in order to support a Fontan patient, which may be a very sexy concept. Now, what is the survival, which is of course important? And at 36 months, for instance, when you look at best medical care in a very sick patient population, you have 0. Best medical care 2, that has improved. This is from studies. You have 24% nowadays. Heart transplantation will give you a 77% overall survival, but when you look at a group that is older, above the age of 65, it suddenly comes down to 65%. And the VAD will give you 68%, 36-month survival. And the latest heart failure study here gives you a 66% 3-year survival. So I believe that, for instance, in the patient population above the receiving donor hearts above the age of 60, the VAD competes very well against a normal heart transplantation at 3 years. And therefore, we should look at this as an alternative and a substitute for heart transplantation in many situations, because we just don't have the hearts available. Now, when you look at the HeartMate 3 CE mark study, that was the first, the beginning of HeartMate 3, and the results have gotten better. You have a 74% 2-year survival. I think that is very, very attractive. And when you look at the results from long-term results from the Revolve registry, you have a 60% 5-year survival. And that now really competes against heart transplantation quite favorably. And when you look into the United States, where just the new heart allocation system has come into effect quite a little while ago, heart transplantation has now not such a great survival any longer, because at 1 year, heart transplantation suddenly only has a 70% survival, which is, when you compare it to results previously achieved with a different allocation system, not very good. And here,
this is wonderful. We're going to ask you to start to tie up if you can.
Yeah,
it's wonderful.
Be as quick as possible. So, briefly about adverse events. Stroke remains something in all devices that is of relevance. You can do certain things in order to bring down the stroke rate with blood pressure management and all of that. And finally, when you compare it again, heart failure therapy, VAD versus heart transplantation, this is our current algorithm. And this is because we just don't have hearts available. We are trying to change this, and we are a bit more successful because we've changed our allocation system in the UK again. But we really don't have, like in the United States, the 30-year-old good donor. Our donor is 55, previous smoker, and all of that. So the VAD has become an alternative. Now, when you look at it, results, quality of life is good. 3-year survival and 5-year survival is not bad. And the thing is, it happens during working hours, and you can control your variables. You can prime your patient and do it whenever you want to do it. So in conclusion, heart transplantation is really great for the individual, but on a bigger level, it's completely irrelevant, because when you look at the numbers, it just doesn't address the problem. But VAD therapy is coming of age, and it's becoming a true alternative and replacement therapy for transplant. And this is how life on a VAD can look like. This patient was there 1,700 days almost on support, wearing his chainmail and armor with a special bump to cover his VAD controller. And by the way, Kolmunk Peter then as I did say, he gets significant complications with all sorts of things, and he elects to have the device removed in the end, which he managed with complications and at great peril. But in the end, he actually recovers his heart and regains his heart function and recovers fully. So that was a recovery therapy in 1820. I think it's not so bad. Thank you very much.
Thank you. Fabulous talk, Andre. Thank you so much. Our next